Good morning.
Morning, everybody, and welcome to IGP Learners. And thank you for joining us on this beautiful day following VE Day. And myself and Andy are here to continue our journey into what post-lockdown primary care is going to look like. And this is clearly quite topical because potentially tomorrow we will find out what the world will look like for the UK in terms of post-lockdown. But we're going to focus more on what primary care is going to look like as a continuation of our earlier episode. We talked about things like demand management and all that kind of stuff before, and today we're going to go into a little bit more depth on some other areas. But how are we doing, first of all, Andy?
Yeah, so today on the agenda is looking at management of long-term conditions and how that might look different going forwards, working with colleagues within our own practices and how that's changed and what we might like to keep, working with the wider MDT, which may not have changed so much, but it might be one of those areas that we can carry some of the learning from COVID forwards and have some rapid change afterwards, maybe, or as we move into another phase of the COVID response, lots of backlog to deal with. And then also, will these changes stick? How can we improve the chances that those changes that we want to keep stay? Because there's going to be some slippage back to the old ways afterwards. So for the viewers, so is it just to think about where we're at in the COVID response? And I think I saw this chart in a communication that was forwarded to us by one of our deputy clinical directors, Rabana. And I think it's a good way of thinking about the COVID response and where we are, because we've been focusing an awful lot on this first wave, but actually there are multiple waves of increased work or change coming for us that we're going to have to face. Lots of focus on this initial phase of increasing hospital capacity, ventilator capacity. But as I've been acutely aware, and I'm sure a lot of our GP colleagues and other colleagues in the hospital have been aware, a lot of routine care has been postponed. We've had a lot of people not coming for routine planned reviews. A lot of those presentations that we might have expected to have had to us of people with red flag cancer symptoms, for example, but also just symptoms of other diseases and illnesses haven't been happening. So we have probably been storing up a second wave, which we perhaps are just beginning to see. And that'll have an impact on the capacity for routine and normal care as well. And then there's also this building wave of just psychological trauma and people who have been affected by bereavements, but also the economic hardship that will come with the aftermath of the crisis. And then it may be months, years before we potentially see a third wave of those people who didn't get their diabetes diagnosed, early, miss an opportunity to do something crucial to intervene and identify a long-term condition, and that might not be identified for a long period of time. So there might be a much longer tail of impact as well. So I just saw that and I thought that was a really nice way of conceptualizing what might be in store for everybody post-COVID, but also allow us to work out how we're going to hit those problems, really. So I thought that was interesting. I guess managing long-term conditions, we're probably thinking about this second wave of those asthma reviews, diabetes reviews, long-term condition reviews that we haven't done, and we're going to have to catch up and do them going forwards. So what might that look like?
Well, it's going to be interesting. And I know that there's lots of concern that, people are feeling we need to protect our NHS, so don't use the service. And yes and no. I'd probably say definitely if you've got health concerns, there are, systems in place to try and help you understand what needs to happen. So there's clearly things like 111, there's a practice, all those kind of things to help you. But I think the other thing that's concerning people is that, so things like clearly cancer referrals have dropped compared to what we would normally see this time of year. Interestingly, things like heart attacks and traumas and those kind of things have massively reduced. Now, is that because everybody's at home or should be at home and therefore less stress, less, those kind of things? That may be part of the reason. But one of the things we are seeing is, unfortunately, some people are, when they are attending, they're attending much further down that journey in terms of where they would have been in their health. So, instead of just seeing sick kids, we're seeing really sick kids, that kind of stuff when they do turn up at A&E. And I think that's one of the things that we're acutely aware we don't want to keep seeing happen. So yeah, clearly the NHS is still open for, normal stuff as well. Just important to, I think, note that you may be dealt with slightly differently towards things were pre-COVID. I think that's the main difference I would recommend to a lot of people. I'm going to cover some of that.
So Gandhi,
Yeah.
Sorry. I was just going to ask. Yeah. So I think a lot of what we've been focused on so far, everybody has, including the general public, is this first wave and how we handle demand, how we switch to telephone first, and how we keep people apart, keep people away from the surgery. And that's meant that a lot of work has been left perhaps undone or postponed going forwards. How are you thinking you might catch that up, and how might technology be helpful?
So I think there's various different ways that's going to happen. So one is trying to just remind patients that, we are open, first of all, and we can deal with things. I think some of the technology adaptations we've taken are clearly we will want to keep. So things like, video consultations, that's something we weren't doing before. We're going to continue doing those. And I think there's going to be definite situations where that's going to be really helpful, both from a patient, but also from a clinician perspective as well. I think a lot of the remote monitoring that can potentially happen. So we talked about, chronic disease management. So things like asthma reviews, things like diabetes reviews. A lot of that work that we used to do can be done remotely, either by video, but more importantly, I think by online consultations. So getting the patients to pre-fill information on forms and that kind of stuff, so that when they do come to us, they're not having to waste as much time, really, because a lot of that work has already been done. Now, that's going to work for some patients. It's not going to work for everybody, clearly. And so there still needs to be that, those systems in place to help those other patients. But one of the biggest things I'm really looking forward to is, because of COVID, most of the world has kind of shifted towards understanding how to use the online world a little bit more effectively. And because of that step change in engagement, I think that's something we can use to provide better services to patients, because we can then either produce more collaborative things, or we can provide care that's more timely, both to clinicians and to patients, and remote working. So from a quality of life perspective for the staff, that was a massive thing before COVID. Loads of people were really struggling with demand, with the workload implications and stuff. And I think we're going to see better improvements in that because of remote working.
And it's not just the patients who are more receptive to digital working. I've been really surprised and impressed by how receptive colleagues have been to it as well, and colleagues across the team at the practice. Through receptionists, nurses, and GPs. Everybody seems much more up for using technological solutions. So I think it's going to be really helpful. We're entering that strange period of time now, aren't we, where it looks like COVID is going to be with us for a bit longer than perhaps we might have initially expected. And now I was initially gearing up for a big bang, a big surge, and then a return to normal. And it's going to be a strange world where COVID's still with us, but we do still need to get on and do our routine reviews, for example. But we're still focusing on limiting contact and limiting access to the surgery. Like yourself, I think a lot of these technologies can be really helpful. I think video is probably going to be a really big part for some of those long-term condition reviews, reviewing mental health, reviewing diabetes, asthma. Is it possible to check asthma technique on video? Yeah, I think it probably is. You can probably do a lot of these reviews there. People will probably still have to come for some things. They'll need their blood tests. They might need some observation measurements, foot pulse checks, blood pressure, and so forth as part of their diabetes review. But that's the sort of thing that can be done quickly, limiting contact, wearing PPE if necessary. And then a wider discussion and patient education can take place separately online, which I think is really exciting. Now, some of the things which I think are coming, and we've seen the beginnings of in the acute crisis, is this making care asynchronous. So by that, I mean getting the patient to do something that's at a different time to when they're with the healthcare professional, like answering some questions about their condition. And I know you've got some good knowledge of some of the players out there that are beginning to make these things available. Might be helpful for the people out there just to hear a few of the players and the names. Like, who have you been looking at during this crisis?
Yes, so I mean, there's lots of different people out there that are trying to look at this, and so in terms of validated ones, you need to look at the dynamic purchasing system, which is an awful name for it when you're trying to reference it, but hey, that's what it's called. And these are companies like, so we've got Accurix, we've got eConsult, we've got Clinic, we've got Ask My GP, to name some of the bigger ones and more well-known ones. But there's loads. I think there's something like 36 odd companies on there, and that's not even including the EHRs people. So, you know, people like System One have their own mechanism called AirMid, EMIS have their own systems and stuff, which are effectively there to try and support patients. And, you know, there's lots of options. They all have different functionality as well. So none of them do the same thing, fair enough. And they all do in a different way as well, which it makes life interesting. Clearly Nottingham, so me and Andy, obviously Nottingham based, we've got one coming called PKB. Well, it's actually already here. So Patient Knows Best. And all these systems are, I think, allow the opportunity to give you asynchronous care to patients at the very least. That's one of the key things. How they do that, how well they do that, that's the part that's very different.
Yeah. So Gandhi, one of the dangers I see going forwards is there's all sorts of really useful apps out there. So I know a lot of people are really enjoying using AccuRx at the moment, and they've got really good functionality to sending structured questionnaires about patients' health that read codes back into System One to individual patients, which is really good. AirMid, the solution from TTP or TPP and System One, looks really good for that functionality as well, and allow you to send to bulks of people. But then on the other hand, the Centre and Department of Health are trying to push people towards the NHS app, which I think is also great as a front door. We've got PKB locally in Nottingham. It's beginning to sound like quite a fragmented ecosystem, and I'm just beginning to wonder whether that it might not matter, but it sounds like there's a potential problem there. What do you think about that, Gandhi?
Well, I think there's definitely issues in terms of fragmentation, and because the systems all do something slightly differently, is that a good thing? I think the key thing that's going to determine how well this goes is the interoperability between these systems and the actual health systems that we use. So clearly, I think to some degree, AirMid has a bit of a plus on top of some of the other companies when it comes to System One based practices, because it's created by System One. So the integration level is unparalleled compared to other systems. But then AirMid requires you to download another app, and that doesn't work directly through things like the NHS app, which there's obviously been a national push to get people to use that, and it's a universal door kind of thing. And I think one of the things that we just need to see is these systems play with each other, and not just play with each other. This is going to be a massive kind of plea. The health system creators, you know, EMIS, System One, Vision, that kind of stuff, they really need to start playing better with other people. They really need to look at interoperability, because until they do that, we're going to continue to see real fragmentation, I think.
Yeah, it's a problem. I mean, I know we've talked about this at my practice, and as we're thinking about what we do next, because we want to do something, you know, next month to address this second wave of catch up. And we've sort of thought, well, actually, it's important to have a single front door to the NHS. But that's most relevant when patients are looking to initiate contact with us. And actually, the NHS app and PKB locally are probably really, really good for that. And that's probably the solution for that. But actually, where the practice is initiating the contact with the patient, and it's quite easy for them to just click a link in a text message or engage, maybe the fragmentation matters a little bit less. And it's more our problem as the people running the system, rather than something that's quite so visible to the patient. So we're probably going to be fairly relaxed about using what we feel works for the moment, while the NHS app and PKB really get up to speed to deliver similar functionality. So that's what we're looking to do.
But it's important to remember, you've got this weird dichotomy of the fact that you're trying to create a system that works for patients, they can use effectively. The purchasers generally of these systems are not the practices themselves. So it's not the GPs, it's not the surgeries. They don't tend to purchase these systems. That's done for them through higher up mechanisms like the CCGs or networks or that kind of stuff. So they may not have direct involvement in the decision to have which system that they have. But it's the practices that have to use it. So if you don't have engagement from the practices and from the GPs themselves in terms of using it, then it's not going to work so well. And it's a weird system that we've created, but it's kind of like you going to work and not being involved or not having any say in terms of what kind of system you use at work, and you have to use something completely different that could change at any point as well. So it's
Well,
frustrating.
Well, you see, that's that. You see, I think the people who run the system think that's how it works. That the patients are the ultimate consumer, and they are, and it's vitally important that they're able to engage with the product. And they think that the consumers are the system level purchasers, but that's not the whole story, because individual GP practices and primary care networks now do make purchasing decisions, and if the system isn't careful, isn't responsive enough, doesn't communicate well enough, and doesn't procure well enough, then the smaller commercial players just sell additional tools directly to the GP practices, like AccuRx and some of the other examples. And that's where the fragmentation comes. And to a certain extent, it's a function of the system that I've just described. It's a problem. Maybe it's a strength, though, because it allows other players to come in, to disrupt, and also to ultimately influence what people use and what's purchased for people. Yeah, interesting. Perhaps seeing some examples of that in Nottingham at the moment. Shall we move on to our next topic, Gandhi?
Yeah, so we've talked about apps that allow the interface between clinicians and patients, but one of the other things that we've seen is a massive increase use in terms of using applications and online systems to support patients. So things like healthcare apps, wellbeing apps are a massive thing right now, in terms of supporting people. And one of the things I guess we wanted to mention is, our colleagues over at Orca, who are effectively the BNF of apps. I mean, we've talked about this on previous episodes, haven't we? And how that can enable clinicians to have good access to what is a good quality app, really. Don't you think? Yeah.
Oh yeah, no, I do. I was just attempting to pull them up on the browser and flash them up on the screen, but I don't think I'm not going to be able to do it quick enough. But yeah, Liz and the team at Orca do a great job evaluating apps to give us that kind of assurance that we're recommending apps that are safe and effective, at least. So they do a great job.
And I think hopefully what we will see in the future is better integration of those mechanisms, so that it makes it easier for clinicians to send those to patients, and also an understanding from patients as well that actually these can be really effective ways of helping them manage their conditions, either from monitoring perspectives or treatment, or whatever kind of thing they need. Because the benefit of that is it's time. It means you get your care a lot quicker, or at least support. So many of you probably remember me saying this in previous episodes, that access prior to COVID in terms of mental health support and that kind of stuff was really challenging. Sometimes you'd have to wait 4 to 6 weeks before a patient would get their initial consultation about counselling and that kind of thing. And I would typically recommend they use one of the various wellbeing apps, not just as part of their treatment, but also as that first step onto the journey for them doing the more complicated things like CBT and that kind of stuff, because a lot of them have those basics involved. And using those mechanisms validated, and that's where Orca comes into a degree, as well as groups like NICE and stuff, can help to give you that information as to what's a sensible thing to recommend to patients and why.
Yeah, excellent. And yeah, you're right. It'd be nice to see that integrated perhaps with things like AccuRx or some of the other topics. I think there's some good opportunities maybe for Orca to link in with the other delivery systems and communication systems that are evolving.
Yeah, I mean, as we mentioned already, the easier you make these things for the clinicians, the more likely it is that they will use them, because you remove those barriers to engagement.
Yeah. So another area that I think has changed an awful lot is this area of how we work with our colleagues. There's so much in here, from remote working to how we're having meetings to how we are supporting one another, both professionally but also emotionally and socially through it. And I think a lot of good things have happened in that space, and we've all got exposure to a lot of new tools and apps. I know that we've had at the practice and on the primary care network, and more widely, much more use of WhatsApp groups, both socially and for professional communications. MS Teams has sort of been procured and launched early during this window, and I think there's been variable uptake across different practices and PCNs, but that looks like a really, really excellent tool, in my opinion. There's been Zoom as well. It's all sorts of different ways of communicating. And I'm just beginning to wonder what will stick, what won't. I suppose the other thing as well to say is, yeah, everybody has started using more of these apps and tools. I think our pattern of communication has changed, enabled by this, but I know that we're having much more frequent meetings in practice. We're having much more frequent meetings in the primary care network. We have a weekly pandemic Zoom, for example, where we were communicating, once every month or two, face to face, if we were lucky before. Yep. So it's not just keeping use of the apps for me going forward. It's picking what's working in terms of our new patterns of using the apps going forwards. And do we want to still meet every week? But maybe that's too much, but maybe every 2 months was too little. So maybe somewhere in between. But yeah, so there's all sorts of things to talk about here. Any observations yourself, Gandhi?
No, I mean, I'd echo a lot of what you said there, Andy. The frequency is definitely something that massively changed. I mean, at one point we were having twice a week meetings within our network, just trying to keep practice updating as to what was happening and some of the changes. And particularly as we set up one of the clinical management centers, that was really valuable to share that information. But at the same time, clearly quite intensive in terms of the, what was happening. Both Andy and I are clinical directors of networks. And there was one period, I think, where for about 10 days, we had a daily meeting between the clinical directors, wasn't there?
Oh gosh, and it lasted at least 90 minutes as well.
Yeah.
But it was very welcome at the time.
Yeah.
It was necessary. And I actually felt quite supported by our superiors who had initiated that, because things were becoming a bit confusing, if you remember, on WhatsApp. And there was a deficiency of communication that was potentially causing some friction points. And that decision to go to daily meetings, I think, helped at that
Definitely.
point. But yeah, it started to get a little grueling.
Yeah, trying to fit that into the day was a bit of a challenge, clearly, because at the end of the day, you've got 24 hours and some of that you kind of need to sleep and eat and do other kind of things. And I think, we were getting to a point also where there has been channel overload, as I like to describe it. And I'm sure many people have experienced this when it's on WhatsApp, or it's on Teams or whatever, email, clearly this can happen, but just too many communications. But what I found really interesting is that the ones that matter, you can generally figure out what they are and focus on those with a little bit of, time and attention. And I know that, many of our AGPLers will probably remember last week, Andy did a really cool episode talking about how to just try and turn down the whole digital stuff, and going analog a bit can help, and definitely recommend that you guys check that out, because I enjoyed watching it as well, which was really useful.
Oh, good. Thank you. Yes, check it out.
Definitely. But I think, in terms of what we're going to stick with, so I think WhatsApp is ubiquitous, that we're going to see that continue, just because it's one of the easiest and most simplest mechanisms for people to communicate across in groups and that kind of stuff. So I don't see that going anytime soon. Teams, I think, is the interesting one. And I don't know if you agree with me on this one, Andy, that I think it has so much functionality, but the current offer that we have for the NHS just seems a little bit lacking in terms of what it could do. So there's certain key features that have, for whatever reasons, been left out for the procurement for NHS workers. So like, for example, the ability to create your own team without having to go to somebody else and doing it, like having the calendar function integrated in what you can see, so you can actually schedule a meeting without having to go through another system. It just seems bitty and fractured again. And this is a common thing we see with the NHS, unfortunately.
So Gandhi, how have we ended up with that? Have we got sort of Teams economy in the NHS, budget version?
I don't know. So clearly, I mean, this is a massive thing that's happened. So they've gone off and procured for all NHS workers Teams. I mean, that is not a small thing to do. Let's be completely honest on here. We're talking, several thousand people suddenly joining an ecosystem or having access to it. And how do you pay for that? How does that work? And yes, we've got it, free to the users for 3 months. And we're about halfway through that, I think. So then there's that question of, what does that mean at the end of the 3 months? Is it going to continue?
Then what happens, Gandhi?
Yeah. And I guess people often ask me how I use Teams in my network and stuff. And I'll be honest, my instant answer is I'm not. And the simple reason is because I don't know if we're going to continue having it after the end of the 3 months. I don't want to invest my time, and more importantly, my team's time, using a new system just for it to potentially be pulled.
Yeah,
Now,
we had a practice meeting on Thursday, and because I'm quite pro Teams, I like it. I think it brings
definitely,
together.
I think the functionality of Teams can really excel what we're doing. I'm going to talk about how it can even help with patients in a second.
Yeah.
But yeah, you're right. It's
Yeah, yeah, really good. And tried to do a little bit of a sell piece on my partners, and one of them quite sensibly said, "But it's free for 3 months. We haven't been told what happens after that. Why should we invest the time moving the team into Teams when we might be asked to pay for it? And the free options might be give us what we need without having to pay extra for Teams, which we may not want to do." So I think being on that 3-month offer is actually being a barrier for adoption, and we need some future guidance as to what's going to happen.
And I think, the whole concept of we may have to pay for it, I don't actually have a problem with that, to be honest, because I think as a mechanism, it can really enhance the work that we're doing. And sometimes you do just need to pay for things to make your life better. So there's that one thing. The part we don't know is how much it would cost. So that's the first thing. So there's obviously always going to be a balance between cost versus benefit. But more importantly, if we're paying for this trimmed down version, to be honest, my answer is automatically going to be no. It's if I'm going to pay for Teams, I want the full fat, proper version, because that just makes life a lot easier. But then, does that mean we get the NHS approved elements of governance that comes with it if we just go for the normal version? And I'm not sure if that's the case. So I think there does need to be some work done, whether that's locally or nationally, just to clarify what the Teams offer is after the 3-month period.
Yeah, great. So Gandhi, to wrap up this section, what does your comms strategy look like for your primary care network and your practice post-COVID?
So post-COVID, I suspect a lot of it's still going to be WhatsApp, because it's the system that everybody uses just to organize meetings. Be very clear, no patient communication is going to happen on that. And I think afterwards, well, we're still going to use Zoom, I suspect, to try and coordinate those meetings again. The interesting part that I'm not quite sure on and haven't quite figured out is how we're going to engage with patients in that element. So discussions about patient care and that kind of stuff, because that's the part I think where we need to see real benefit. That's where Teams could do it really, really well.
Well, which brings us on to the next section, which is communication with the wider MDT, because I think it is different for the reason that you've just identified. Is we talk within our own teams, and generally we're organizing ourselves. They're business conversations, they're service delivery conversations, but they're not conversations about patient care, because generally we can do that within our clinical system. We can send each other tasks, we can send each other pop-up messages when we're all working. We don't have a need to do that. Where there is a need to talk about patient care digitally, potentially more in the future, is as we try and get some of our multidisciplinary teams up and going during this grey post-COVID surge, but we still need to social distance area. How are we meeting with the palliative care team, with the district nurses, with our midwives, health visitors, and school nurses?
Yeah.
But we need to get that started. And what will that look like?
Exactly. And I think until we've got that understanding, it's going to be a bit more challenging. I think Teams is definitely one that I see being able to facilitate that, because simply you just need an NHS email address to do that. And most of all the people we just talked about have that. There is also this element that apparently Teams will allow patient consultations as well coming forward. So when that happens, it massively improves, the ability and its way that we can use it. Other systems, so I've heard of a couple. So Accurix, to a degree, allows some of the video consultation mechanisms to happen, because you can bring other people into meetings, but it's a limit of 4 people. Visionable, I believe, is another system that can potentially offer some of this functionality, as well as the meetings and the kind of like Zoom-like element. Potentially Zoom, but you're going to have to pay for the higher version. You're going to have to pay for the healthcare version of Zoom, which comes at an increased cost. I think they're the best ones I can think of off the top of my head, to be honest.
Yeah, I can't think of any more. I think what is going to be really interesting to watch is what people do around their virtual care home ward rounds.
Yeah.
Because I think that's going to be the testing ground for primary care networks and associated services in terms of moving to a virtual MDT. It's probably the first example of sort of mass adoption of a virtual MDT. So I think a lot of what people go with for that might stick. And I think people probably going to initially go with Teams because it's currently free. Everybody across the NHS has sort of received the messaging about it. So our district nursing colleagues are aware of Teams, it seems.
Yep.
So I think there's going to be a reduced barrier for getting everybody, and everyone's got an NHS email address. So the barriers to get people on Teams is going to be reduced. So I think we're probably going to find that Teams may be the winner here. That's my prediction.
I think it's because Teams has a lot of the governance already baked into it, which just makes that process so much easier for people to consider. Clearly, I don't think it's going to take much for one of the other players to catch up. It's just whether they've got the will to do it for our market, and also the functionality. But you know what? Until we get that full fat Teams, I don't know.
No. Okay, all bets are off until we get that. And I was just going to reflect on, because we're going to have to do that during this grey post-COVID surge period where we can't physically be with people. But going forwards, I think there's a lot of advantage. It's one of those things. The video MDT, the virtual MDT, I think is going to be one of those things that we want to hold on to longer term going forwards. For all the things we talked about before, really, people won't have to travel. People can dip in and out just for those bits that are important for their care. They can potentially even catch up afterwards with recordings. So I think there's so many. Candy, have you frozen?
No, I'm still here. So I was just checking the chat.
You must move a little bit more.
So sorry, apologies.
Still alive. Yeah. So I think, it's going to be one of those things that we want to take forwards into the future.
Definitely. So yeah, apologies everyone. I was just checking the chat. So hi to Christian. Thank you for joining us. Yeah, we'll put the links up to those apps and the systems that you can look at the end of the live stream, if that's all right, because we don't have that link just available, but it will be there on the show notes. And for many of the stuff we talked about to all of our EGP learners, either listening live or later down the line, all the links will be in the show notes. So feel free to check them out down below. So I guess the next question is, how are we going to move forward?
Absolutely. Will these things stick? Yeah, because it's great to think, the world's completely changed by COVID and we're definitely going to cling on to some of these positive changes. But will we automatically do that, or will our behaviour, our patient behaviour, our colleague behaviour revert to normal? The NHS has been quite adaptive during this period, and that's been fantastic. But will the old inertia and resistance to change take root again afterwards? What do you think?
I think we're going to see a paradigm shift. Simply put, there's no other way to describe it. I think both from clinicians' perspective and staff, and also from patients' perspective, because people will now see what is possible. A lot of the apprehension, a lot of the anxiety that was there around what may happen, well, let's be honest, it's happened. Yeah, we've done it. And yes, there are definitely parts of this about looking at the after effects and how that's going to work. But I think for many people, the functionality of what it's enabled them to do is something that they're not going to forget. Will we see a bit of a step back? I think probably, because I know many people are missing some parts of things. So like the face-to-face contact, that needs to improve. Let's be clear about that. We probably shifted the needle a little bit too far at the initial outset, and it does need bringing back a little bit. But that doesn't mean, I personally think, that we shouldn't lose a lot of the amazing stuff that we've gained from doing this and the ways that we can work. And purely focusing on the clinician part, the opportunities that remote working can bring to work-life balance, to stability, to how things are functioning, I think that can't be missed. I think from the patient's perspective, I think many patients who have experienced this will think, actually, I can have a remote consultation. It means I don't have to take half a day off work to go see the GP and that kind of stuff, or I can send messages about this, or I can get my fit note through a text message and then it works perfectly well, so I don't have to go back in to collect it. I don't have to factor those things into my day. And being a bit more responsive with that asynchronous care, I think, is going to make things a lot easier. And also, what I'm really hoping, and I know I've said this on almost every single one of the podcasts we've done since this started, I'm genuinely hoping that self-care for patients improves, because I genuinely do feel that the needle swung far to the left in terms of people coming to see us for every little thing. And whilst completely there is going to be situations where people need to see us for potentially simple things because of their own health issues or whatever, yeah, I do genuinely feel that there was too far of a swing towards that point, and that actually people now recognizing that I don't necessarily have to see the GP after having a fever for 10 minutes or having coughed twice. And I genuinely hope that that part of things has improved.
I agree. So how do we make sure that we cement some of these changes is $1 million question, I suspect. I know one of the things that we're planning on doing as a practice, and a lot of the other local organizers, and as PCN, because I'll make sure it happens, and a lot of the other local organizations, is deliberately and formally taking stock of what's happened, so that we can talk about what we've learned, what we all liked, and deliberately plan to keep some of that. And I think just taking that formal step to together do those things is one of the things that will help these changes stick, I think. I'd be interested to know what else people are planning on doing, because we'll also have a go at doing that in the organizations I'm involved with. But that's one simple step that I can think of. I don't know if you've thought of anything else, Gandhi.
Well, I think the other thing is also showing the patient journey, because at the end of the day, if the patients don't understand the difference that's happened over this time, then it's going to be hard to help them remember. So, you know, potentially getting your PPG involved and showing them their positive experiences that they've had throughout this period, in terms of, you know, some of those things we talked about, how, you know, actually I can have most of my chronic disease management done remotely, and then I just potentially only need to go in once a year rather than 2 or 3 times a year to have various things done, because it can be coordinated at my leisure, you know, that kind of stuff. And I think it's important to reflect on the impact that has on the patient's life in how it can help them. And also, you know, for those that have significant needs, about showcasing those resources. And again, it's those case studies, isn't it, Andy? You know, showing the patients from the patient's voice, not just from the clinician's voice. I think that's the important thing to remember. It's so much more valuable coming from both, not just the clinicians, not just the patients, but both of them saying that together. That's where the real power is.
Yeah, that's true. Yeah, we need to, the patient group is something that we haven't continued actually digitally, and maybe that's something to look at as we move into this grey post-COVID area. Shall we move on to our story of the week?
Will do. Just before we do that, though, one quick mention, because you just said it there. So if people are interested in how you can have a virtual patient participation group, so we did a video about 4 or 5 months ago with Simon Elcock. I'll make sure it's in the show notes so you guys can find it easier, and afterwards in post-production it'll be in the little eye thing at the top. But it's basically how to live stream your practice effectively for meetings and that kind of stuff for engagement. I can't remember the name of the title, I'm afraid, apologies, but it'll be in the show notes, and definitely have a look at how much impact that can have. And that was pre-COVID. Post-COVID, I think you're going to get even better engagement, because so many people have shifted their life to online.
Yeah, that'd be a great one to revisit, wouldn't it? If we do some experimentation and revisit. Cool. So thanks for joining us on this sunny Saturday morning, or if you're watching later, thanks for watching. Go out, enjoy your days, but do engage with us on Twitter, on the YouTube comments, which is really popular, and we try and reply to every message. And anything else I've forgotten, Gandhi, before we say goodbye?
No, if you are listening to us on the podcast, so we will get this sent out to you guys, definitely subscribe, leave a review. We'd love it when people do that. And make sure you ring the bell here on YouTube, subscribe, all that kind of stuff. We'd love it if you can keep in contact with us. And as always, EGP Learning is here to help save you and your patients time by taking hands in your primary care and learning. And we'll catch you in the next episode.